Hello and welcome to the second in our series of presentations on somato autonomic regulation of cardiovascular function. In this presentation, what we want to do is to look at how the autonomic nervous system regulates cardiac rhythmicity independent of somatic stimulation. Previously, we've seen how the sinoatrial node imposes an innate rhythm on the heart, and we had introduced the concept that the autonomic nervous system could modulate this innate rhythm. The sympathetic neurotransmitter norepinephrine causes heart rate to speed up. Norepinephrine does this by encouraging the inward flow of sodium through funny channels in the cells of the sinoatrial node, and this raises the membrane potential quickly towards the threshold for depolarization. Norepinephrine also increases the rapid inflow of calcium after the threshold is reached, and this causes a faster, stronger action potential. The parasympathetic neurotransmitter acetylcholine causes heart rate to slow down. Acetylcholine does this by inhibiting the inward flow of sodium through funny channels, and this delays the rise of the membrane potential towards the threshold for depolarization. Acetylcholine also dampens the rapid inflow of calcium after the threshold is reached, and this causes a slower, weaker action potential. As we have seen, the action potential which starts in the sinoatrial node spreads throughout the muscle tissue of the heart, causing contraction. The actual contractile muscle cells of the heart generate action potentials, but do so in a way which is different from that of the sinoatrial pacemaker cells. In contractile cardiomyocytes, the action potential is also initiated by fast sodium channels. In this regard, cardiomyocytes are similar to skeletal muscle cells. However, the initial depolarization is then reinforced and drawn out by slow calcium channels, which provide a long influx of calcium to sustain the action potential. In our figure, the thick yellow line represents the cardiomyocyte's membrane potential. The dashed red line represents the rapid opening and closing of sodium channels to initiate the action potential. The dashed blue line shows the slower opening and closing of calcium channels to sustain a long action potential. The dashed green line represents the opening and closing of potassium channels as the cell repolarizes and returns to its resting membrane potential. This sequence of events takes about 200 milliseconds, which is approximately the duration of a ventricular contraction. Sympathetic stimulation facilitates the flow of calcium into the contractile cells, and so permits a stronger contraction. Now that we understand how action potentials are formed in pacemaker cells and contractile cardiomyocytes, let's follow the movement of the action potential through the heart and see how it causes contraction. Quick quiz. The neurotransmitter which encourages calcium to enter cardiomyocytes and thereby produces a stronger depolarization is once the impulse is picked up by the penetrating portion of the atrioventricular bundle, it is conducted quite quickly through the fibrous skeleton of the heart and into the interventricular septum. The cells of the penetrating portion of the atrioventricular bundle are large in diameter and have lots of gap junctions. This is why they are able to transmit impulses quickly. After about 1 to 1.5 centimeters, the bundle divides into left and right branches, which ultimately divide into the radiating fibers of the heart, also known as the Purkinje fibers. These fibers eventually blend into the contractile cardiomyocytes so that the cardiac impulse is carried to virtually all of the cells of the myocardium. Transmission through the radiating fibers is quite brisk, so that the ventricular myocardium contracts as a whole. In fact, from the initiation of the action potential in the sinoatrial node to complete depolarization of the ventricles normally takes just a little over 200 milliseconds, about 1/5 of a second. All of the cells of the electrical conduction system, in fact, all of the cells of the myocardium, are spontaneously excitable and, if left to their own devices, will generate action potentials. However, since the sinoatrial cells are the least stable, they normally discharge first and drive the other cells to depolarize. Parasympathetic stimulation tends to stabilize or hyperpolarize pacemaker cells so that the rate of discharge slows down. Sympathetic stimulation increases permeability to sodium and calcium, making it easier for pacemaker cells to discharge. Quick quiz. Approximately how long does it take for depolarization to spread all the way through the atria and ventricles? If the sinoatrial node ceases to work, or if there is a failure of transmission anywhere in the conduction system, then the natural excitability of the cells downstream from the obstruction has a chance to express itself. Consequently, in the absence of stimulation from the sinoatrial node, the atrioventricular node will soon develop a spontaneous rhythm of 40 to 60 beats per minute, which is adequate to sustain a sedentary lifestyle. If the atrioventricular node fails, then cells downstream in the ventricles may form an ectopic focus and spontaneous discharge at a slow rate of perhaps 20 to 40 beats per minute. As you can imagine, such a slow rate is not compatible with a very active lifestyle. Additionally, the atria may continue to beat in an ineffective and uncoordinated manner, further eroding the efficiency of the heart. The electrical activity of the heart can be sensed by electrodes on the surface of the body, so that it is possible to monitor the function of the electrical conduction system. The graphical representation of this recorded activity is an electrocardiogram, abbreviated ECG or EKG. We can imagine the wave of depolarization as, on average, moving from approximately the suprasternal notch down and towards the left anterior axillary line at about the level of the fifth rib. Therefore, an ECG electrode aligned with this axis would measure an increasing current as first the atria and then the ventricles contract. This, in fact, produces the classical upward P waves and QRS complexes that we are used to seeing on representations of ECGs. Repolarization of the myocardium moves in the opposite direction, but involves the opposite electrical phenomena at the cellular level, and so it would also produce an upward deviation, the T wave, on our ideal ECG. As you can imagine, the precise shape of a recording on an authentic ECG will depend upon the exact placement of the electrodes with respect to the actual electrical axis of the heart. Also, the amount of tissue, for example fat or muscle, separating the heart from the electrodes will affect the amplitude of the waves. ECG can obviously be used to determine heart rate and rhythmicity. It's a simple matter to measure the distance between successive cycles, for example the RR interval, and thereby calculate heart rate. Fluctuations in heart rate tell us about the stability of the electrical conduction system. Changes in the shapes of waves also suggest changes in the pathways that the cardiac impulse follows. Beyond the intrinsic rhythm of the electrical conduction system of the heart rate is regulated on a beat-to-beat basis by a short feedback loop which involves peripheral vascular baroreceptors, brainstem nuclei, and autonomic cardiac efferent fibers. Different classes of baroreceptors within the carotid sinus respond to systolic, diastolic, and pulse pressure, and then convey this information to the brainstem via the carotid sinus nerve branch of the glossopharyngeal nerve. Baroreceptor afferents project to the intermediate general visceral region of the nucleus tractus solitarius, the NTS. From the NTS, afferent information of different types is relayed to various centers, including the insular cortex, the periaqueductal gray of the midbrain, the parabrachial region of the pons, and the ventrolateral medulla. Baroreceptor information is especially relayed to the caudal, then rostral ventrolateral medulla and cardiovagal neurons. Receptors similar to those of the carotid sinus, but perhaps less studied, have also been identified in the aortic arch and the myocardium. Additionally, pulmonary and thoracic stretch receptors also have a small role in modulating the rhythmicity of central autonomic neurons. There may also be very short feedback loops by which intrinsic cardiac neurons increase their activity in response to local mechanical stimulation. Some vascular and pulmonary baroreceptors convey afferent information via the vagus nerve, giving this nerve an afferent and efferent role in the reflex regulation of the cardiac cycle. Quick quiz. The most important visceral sensory nucleus of the brainstem is the visceral pain, and perhaps some baroreceptor information may also enter the dorsal horn of the upper thoracic spinal cord and ascend via the spinothalamic, spinoreticcular, and spinomesencephalic pathways to influence baroreceptor reflex behavior. All of this may seem a bit complex, and so it is useful to first focus on the functions of the baroreceptors in the carotid sinus. An increase in the discharge rate of these cardiovascular baroreceptors, as occurs with increases in blood pressure, results in a reflex inhibition of presympathetic neurons regulating output to the cardiovascular system, as well as an increase in cardiac vagal activity, and so a decrease in heart rate. Within the normal range of blood pressures, it is probably the involvement of the parasympathetic efferents which is more important. It is thought that the primary homeostatic purpose of this feedback system is to maintain mean arterial blood pressure around an optimal set point, allowing that the set point may vary in the long and the short term, both in health and as a result of disease. In any case, when the blood pressure goes up, heart rate goes down, and vice versa. You will recall that when we inhale and expand our lungs, pressure within the thoracic cavity decreases slightly. This is in fact what draws air into our lungs. That decrease in intrathoracic pressure, however, also means that there's less pressure on the heart and the large blood vessels of the thorax. Consequently, our blood pressure drops slightly every time we inhale, and our blood pressure goes up slightly every time we exhale. These small, regular fluctuations in blood pressure are picked up by the baroreceptors of the carotid sinus and relayed to the nucleus tractus solitarius. The nucleus tractus solitarius sends this information to the dorsal motor nucleus of vagus, and so the vagus nerve responds by increasing or decreasing output to the sinoatrial node. When we inhale and blood pressure goes down, vagal output to the heart decreases, allowing the heart rate to increase. When we exhale and blood pressure goes up, vagal output to the heart increases, allowing heart rate to decrease. In summary, when blood pressure goes up, heart rate goes down. When blood pressure goes down, heart rate goes up. In this way, we balance heart rate and blood pressure to keep blood flow to the brain constant. However, the increase in heart rate which accompanies inspiration probably also serves a role in increasing respiratory efficiency. More blood flows through the lungs when they are inflated, and so when gas exchange is greatest. Noxious input, and so activation of the periaqueductal gray, tends to dampen baroreflexes by augmenting the activity of cardiac sympathetic efferents. This makes sense since it may be advantageous as part of a short-term fight or flight response to have higher blood pressure when we first detect pain. Conversely, baroreceptor excitation also depresses somatocardiac sympathetic reflex responses to noxious A and C fiber excitation. In other words, if blood pressure is already elevated, we do not allow it to become much more elevated by the introduction of pain. The baroreceptor reflex works very quickly on a beat-by-beat basis and is very sensitive. Rhythmic oscillations in intrathoracic pressure imposed by the respiratory cycle modulate the normal fluctuations in blood pressure which result from the cardiac cycle. Hence, via the baroreflex, the respiratory rate entrains rhythmic variation of heart rate. This oscillation in heart rate, known as the respiratory sinus arrhythmia, is largely attributable to vagal activity in conscious humans at rest or during low levels of physical activity. Somewhat slower intrinsic oscillations in sympathetic preganglionic neuron activity may result in rhythmic contraction and relaxation of blood vessels, with subsequent superimposition of an additional low-frequency oscillation in blood pressure and so heart rate. Since the slower sympathetic and faster parasympathetic oscillations are occurring simultaneously, the result is a literally chaotic variation in cardiac rhythm, resulting from the complex interaction of reflexes mediated by vagal and sympathetic cardiac efferents. The relative roles of the sympathetic and parasympathetic systems in heart rate variability differ between species according to the access of different efferents to the myocardium and to the electrical conduction system of the heart. Quick quiz. Match the phase of the respiratory cycle and the change in vagal output to the sinoatrial node. Next, we will turn our attention to the details of sympathetic innervation of the heart. Thank you.